Hello, everyone. My name is Benjamin Day,
And I am Gillian Mason.
and this is Medicare for All, the podcast for everybody who needs health care. It looks like I actually startled you with that intro. It was so
You
loud.
did. You're very high energy.
Yeah, it
Why are
varies
you
from,
so excited today, man?
well, it varies from episode to episode, but
It
this
does.
week, you may not know this, Jillian. I mean, I know you're co-host of the show, but we're going to be doing the mailbag episode.
Mailbag.
The rarely seen, fleeting, rare mailbag episode where instead of us ranting about a particular topic or inviting a guest on who actually knows what they're talking about, we take the questions from Medicare for All activists across the country and from folks who listen to the podcast, and we kind of answer them and get a view on the state of the Medicare for All movement and what's on people's minds. So we got some great questions that people submitted over the past week, and anyone who is watching live you can just write your questions in the comment section on Facebook, Twitter, or YouTube, and we'll see it and we can respond to you. We got too many questions to go through all of them, unfortunately, but we'll get to as many of them as we possibly can, and we got some really saucy ones. So well done, listeners. If we have time, and I really hope we do, we can even read some questions from our haters, which are my absolute favorite communications that we get on a day-to-day basis.
Our haters will hate, it turns out. Even if you're just trying to get healthcare for everybody.
How dare you? How dare you? Asshole.
Yeah, fuck that. All right. So shall we launch into this, Ben? I want to ride your wave of excitement.
Let's do it.
All right. So first question. This one is actually specifically for Ben, and it's from some anonymous person in Texas. Gillian seems both beautiful and brilliant. What's it like working with her?
Oh, wow. Anonymous in Texas. Isn't that the state you're in, Gillian?
That might have been the question that I wrote in
I wonder.
job performance review.
Well, let me tell you, Anonymous in Texas, it's very intimidating working with someone of the caliber of Gillian. But I can give you a brief window into, for example, the last half hour of us working together where we were prepping for this episode, where Gillian was complaining about the fish smell just invading her house because her partner cooked fish, and it was terrible and almost intolerable. And then we were talking about what is the scent version of visualizing something, like visualizing how something looks. How do you smell-ize what something might smell like that you're not actually at that moment smelling? And I think that was probably a solid 20 of our 30 minutes preparation for the podcast episode.
That's correct. And I'm really glad that made it into the podcast, because otherwise we would have done that full 20 minutes for nothing.
Exactly. And people wouldn't have that window into how amazing it is working with Gillian Mason on the podcast. I thought it was pretty great and actually really profoundly deep, this question we came up with, which no one has the answer to. Unless someone does, please put it in the chat section.
Yes.
All right. So I wanted to read for you, Gillian, one of the questions we got from Susan Udin in New York. Susan wrote to us, I was in the hospital a few weeks ago for 2 days. I went due to symptoms of stroke, in parentheses, aphasia. Aphasia, I think, is where you lose the ability to communicate, on instructions of my doctor's office. So her doctor had her admitted to the hospital, or suggested she go to the hospital. When I got home, I discovered a statement in my discharge papers that I hadn't actually been admitted. I was just there, in quotes, for observation. Then a few days after that, I got a letter from Highmark, which I believe is her insurance plan, my healthcare non-provider, she calls it, that they deemed the stay and the tests not to have been due to an emergency and were thus not going to pay the costs. My questions: who profits from such non-admissions? Can Highmark get away with not paying? And are the hospital and Highmark in cahoots?
I like the use of the term "in cahoots." Something you don't really hear that much anymore, and yet it does kind of conjure up the kind of backroom gangster kind of milieu that actually would produce a decision this cruel and shit.
Horrible. Yeah.
What do you think, Ben? Can they get away with it?
I mean, they can, but and Susan, I've had basically this exact thing happen to me also when I was living in New York, where I was admitted to the hospital for a panic disorder for 3 days. I got out. My insurance company, which was Aetna, said I should not have been admitted to the hospital in the first place. They claimed I should have been treated on an outpatient basis. And then they refused to pay the bill. And like you, I had just been in the hospital because my doctors said that's what I should be doing, and they admitted me to the hospital. I didn't admit myself to the hospital, and you didn't admit yourself for observation. And if you've lost the ability to communicate, I think it's an urgent, important emergency issue. I'm no fucking doctor, but that's a fucking emergency. So
yeah. That feels like crisis worthy to me.
Yeah. I would say what's going on here is that many insurance companies deny a huge percentage of especially expensive hospital admissions because they don't want to pay the bill. And they know, even though they're going to lose on appeal most of those, probably the first step was that your hospital appealed the denial. And then you in the state of New York have the right to continue appealing that up all the way up to a state review board outside of the insurance company. So make sure you continue to appeal this, because it's totally fucked up and wrong. So they can get away with it, but you do have some rights and the ability to protect yourself from getting stuck with this bill. In terms of, are the hospital and the insurance company in cahoots, I would actually say probably not, which is surprising. But this means the hospital is not getting paid for the care they provided to you. So they usually want to get paid, so they're going to fight to get that bill paid. Because if the insurance company doesn't pay it, they have to collect it directly from you. And most people cannot afford to pay for a hospital admission because it's thousands and thousands of dollars. And they know they're probably going to have to negotiate with you a lower payment and try and get you to pay it over a long, long period of time. They would rather just have the insurance company pay it right away. That doesn't mean that hospitals don't do terrible shit all the time, and doesn't mean that they're not greedy and trying to get money from you and from the insurance company. But in this particular case, I don't think they like denials. They like to be paid. So,
so they're symbolically in cahoots in that they support this evil healthcare system, but they are, in this particular case, they would prefer that the insurance company roll over and give them their cash.
Exactly. Yeah, there are ways in which hospitals and insurance companies are in cahoots. There was in my state of Massachusetts, there was a big investigative sort of journalistic expose where they discovered that the biggest hospital chain and the biggest insurance company in the state had basically met behind closed doors. Their executives had met and decided, why don't we just both charge high prices? Hospital, you charge a high price to the insurance company, and we'll pass on those high prices to, whoever buys our health insurance. And this is illegal. You can't do that. They're supposed to compete with each other and try and get lower prices. But behind closed doors, they're like, let's just screw over the people paying for this whole thing. And we can both get rich in the process. So they are in cahoots in lots of other ways.
That is, yes, that's good. As long as it just confirms my instinct that hospitals are also a real problem.
Oh, yes.
Speaking of problems, we got a bunch of questions that were about publicly administered health insurance, Medicare as a model, Medicare privatization, the model of other single payer systems, and folks were kind of wondering what problems might be inherent to them. So,
right. These are great questions.
Yeah, these are some great questions. Did you want to start off with our?
Yeah. Yeah, this first question was from someone in Minnesota, anonymous person in Minnesota, and I actually really appreciate how many people told their personal stories when they were writing to us. It's really powerful, and it helps us, put a reality onto these questions. They're not just abstract policy questions. So this person wrote, I am disabled and I have Medicare. I also need to have supplemental health insurance and prescription drug coverage. The total cost for Medicare and my other healthcare coverage is over $7,000 a year. My gross annual income is $20,000. So that's almost half of this person's entire annual income. Immediately thrown away on just the upfront costs of healthcare. Sorry, that was my parenthetical in the middle of their comment. Yeah. Then they go on and say, it is very hard to live on what is left of my income after paying for Medicare and the supplemental insurance and prescription copays I have. Medicare is not good insurance unless you are very healthy or have a sizable income. As it is now, I don't think Medicare for all would be a good deal for most Americans. It sure is not a good deal for me. So, Jillian, what do you think of this person's very good question?
I think it's some real shit, right? Like, I mean, we do, we talk about Medicare for all. We use that terminology, but yeah, we know that Medicare doesn't work for everyone, and that the problem still has, that the system still has a lot of problems. My gut feeling is that a lot of the problems in Medicare have to do with the underfunding of Medicare, and cost cutting measures within the program, which are usually necessitated by some kind of terrible compromise with conservative politicians who demand some kind of austerity because they've projected this false controversy, right? That Medicare is going to end, and yada yada yada.
Yeah. That's I would to this person who raised this great question, I would say one very important thing, which is that the Medicare for All bill does not actually just expand Medicare as it currently is. In fact, so it fills in all of the gaps that you mentioned, that this person mentioned. It does not have any premiums. It doesn't have any copays. The Bernie Sanders bill has very, very small copays for some prescription drugs, I think. But by and large, you would not have to, that's $7,000 a year you would not have to pay for the Medicare for All program. If we just took Medicare right now and expanded it to everyone, I think, like this person was saying, it would be a real problem. And in fact, it would be unpassable as legislation because so many people have better private health insurance coverage than Medicare provides. So Medicare for All, it's really kind of a messaging tool that's been proven to be effective just because Medicare is the only universal program we have in the United States, public and universal, and it's less wasteful than private health insurance is. But we do not actually plan or intend to or support just expanding Medicare as it stands to everyone. We want to make Medicare better, improve it so it's comprehensive, and then expand it to everyone. So
yeah. Good point. So, all right, we have a question from Jan in Colorado that I think sort of ties into this a little bit. So Jan sort of talks a little bit about some of like the terrible privatization efforts that we're seeing in Medicare through the Medicare Advantage plans, the privatization regarding the DCEs, which we've talked about before, direct contracting entities, all these different and the privatization of the VA, all these the stuff that we talk about every week. And so this leads her to her question. All right. How can we convince the public that Medicare for All will be different and not fall into the hands of the political party currently in office who would like nothing better than to prove how wrong it is for the government to make rules around healthcare? I've heard that services would be determined by a board of experts and patient advocates, not politicians, but who would be responsible for appointing those experts on the board, and who would be selected as a patient advocate? I love and advocate for Medicare for All, but I'm having the same worries about politicians owned by special interests on both sides of the aisle. So good.
Yeah, that's a good question, and we have another question similar to that came from James in Illinois. I think I'll just read the second question right now since they're so similar. James said, "Will Medicare for All be such that members of Congress and their families will have the same coverage as me and my family, such that they will make it the best that it can possibly be? Will there be any people in charge of it, by it meaning the Medicare for All system, like CMS, that can distort it like CMS does now?" So James is talking about the same thing about these privatization efforts of Medicare currently, and will Medicare for All be the same? Can Medicare for All be kept free of corruption, confusion, and consternation?
Ben, you got to start out by telling the people what CMS is.
Sorry. Oh, yeah. So CMS is the Centers for Medicare and Medicaid Services, which is the federal government entity that runs Medicare and that also administers the federal part of Medicaid, which are run by the states mostly.
There we go.
Yeah. So, I would say my first thought for both of these is that if you look at the countries that have universal health care right now, which is all of them except for us in the developed world, in all of them, there are attacks on the public healthcare system, attempts to privatize it, attempts to undermine it, to introduce the for-profit incentive, to introduce market-based reforms. And it is a constant, decades-long fight for all of them to protect the public system, or to expand the public system, to make it even more public over time and more of a right. So I'd like to say that, you can win this and then we can all retire from healthcare activism, but that is not the case. But the good news is that it is much, much easier to fight to preserve an existing program that has millions and hundreds of millions of recipients and people who benefit from it than it is to try and win a new system. And it is a lot easier for us actually to fight and defend Medicare right now than it is to create a Medicare for all system. As you can probably tell, you'll notice Republicans do not try to get rid of Medicare. They'll try to privatize it, but you'll see very few attacks to actually eliminate the entitlement of Medicare to a universal healthcare system for seniors, or an attempt to roll back the benefits of Medicare. That's like a third rail for all politicians, basically.
Yeah. I mean, folks might remember during the Affordable Care Act fight, the Tea Party slogan at the time was like, "Keep your government hands off my Medicare."
Right? Hilarious.
Like, we really need Medicare to exist, but let's deny that it's a government program.
Right. Yeah, and I mean, I think once you have the system in place, it is very hard to get rid of the actual benefits and the universality of it. They're trying to tinker and privatize around the edges a little bit, and you just have a new fight after that. But it's a fight where everyone actually has access to healthcare. And I think the reason it's so hard to successfully attack Medicare from the right or from the left is that there's just millions of seniors who benefit from Medicare who are going to be directly impacted by any changes you make, and who vote and get really pissed off and harass their legislators if anything is changed that impacts their pocketbook or anything else. So once you have the program, it creates the constituency that fights for the program. And we don't have that.
Bless all those elders who are out there fighting for their coverage. It's badass. We love it.
Yeah, and shout out to Social Security Works, who our allied group who fights for Medicare for all, who they do similar stuff for Social Security to make sure that Social Security isn't privatized or reduced, and they actually try to expand Social Security benefits. And they've been fighting for that kind of parallel fight for many years. So.
God bless. That's wonderful. Okay, here's another question from our friend Alex, and this is another question about that kind of the universal healthcare model, and some of the kind of problems we hear about it. Do countries with universal healthcare run into significant shortage problems, or are the systems generally well equipped?
Yeah, that's a great question. And the answer is complicated, so I'm not sure how to. I guess I'll try to boil it down. I mean, the nice thing is that if you continue your current spending, but you switch to Medicare for all, you're cutting out a lot of waste. You're cutting out administrative waste. You're cutting out profits which don't help healthcare at all. So you can literally kind of redirect your same resources, spend more of your resources on actual clinical care, caring for patients, and less the sort of middlemen skimming off the system. That's like the real basic of how Medicare for all works, how you can pay less but cover everyone and provide better care. But that being said, it varies how well countries with universal health care, how much they have in terms of do they have enough specialist physicians to care for their entire population without wait times? Do they have enough MRI machines? Do they have enough CT scanners? Do they have enough providers in rural areas? These are all questions that once you have a universal healthcare system, it actually lets you plan to address all those things, which we don't even have the ability to address across the whole country. But, for example, a lot of the horror stories that people hear about Canada, where it's like, oh, you have really long wait times in Canada. A lot of those actually come from the 1980s when right-wing prime ministers were elected, and they slashed the funding for the national healthcare system. They didn't just like fail to increase funding to meet inflation. They actually reduced funding across the whole country. So the spending went down from year over year. And if you do that, if you don't fund the system adequately, you are going to have problems, right? You are going to have shortages. But I don't want people to think that we do not have shortages in our healthcare system. We have massive, massive shortages.
Yeah, I think we've all seen that during COVID. Yeah.
Yeah, exactly.
I was literally sitting in the ER in Corpus Christi in Texas. I was sitting in the ER waiting to be seen, and I was literally watching a video of I was watching the news, and the news was covering how there were no beds in the hospital.
Right. God, that's meta in a horrible way. Yeah. Yeah. And, even COVID aside, I have neuropathy in my hands and legs. I have this sort of nerve damage. And I only have it for the rest of my life because I couldn't get an appointment with a neurologist for 3 months. And when I did, it was easy to fix, and I would not have these symptoms now if I was able to get in quickly to see a neurologist. And I live in Boston, like the fucking center of, one of the biggest healthcare industry centers in the country. So we do have the same problems, but they're created by different things, right? It's not by the government underfunding the whole system. And then it starts leaking around the edges. It's because certain things aren't profitable to hospitals or doctors, so they don't want to do as much of them. And certain other things are very profitable and they want to do more of them. So
yeah. But I think you're like pointing out like a really important distinction, which is there's the system that you set up, and then there's the resources that you put into the system.
Right. Exactly.
Right?
Yep.
And how many resources you put into the system is determined by a million different things, including, sometimes legit austerity and most of the time manufactured austerity.
Yeah. But I would want to emphasize to Alex that being underfunded in a country with universal healthcare is way better than being fully funded in a country that has our healthcare system. Because even when there's scarce resources, when they're equitably distributed and everyone has access to at least basic care, that is so much better for all of our access to care and our health outcomes than not being able to afford care at all. Even if you look at developing countries like Cuba, for example, Cuba is a pretty poor country. They spend something like, I don't know, I haven't looked up most recent data, but it's like $300, $400, $500 per person on healthcare. We spend like $8,000 more per person on healthcare. But Cuba has a longer life expectancy because they're very scarce healthcare resources. They distribute it more equitably. They have a universal healthcare system. So you don't, under any circumstances, want to choose our system, no matter how badly underfunded the public universal system you'd be replacing it with is. So.
Yeah. I just want to say that we have some folks who are joining us live, which we love. And so hello to one of our supporters, Torrential Rage. Hello, good evening. Thank you.
I couldn't sum up my feelings about this topic any better.
I know, right? And then Linda Brewster was asking, what is the name of the gentleman who is speaking? And the answer is that gentleman is Ben Day, and he doesn't get called a gentleman a lot. So
I've been outed.
Very flattering.
And probably inaccurate, but thank you anyway, Linda.
We never mentioned this on the podcast, but Ben Day is actually the executive director of Healthcare Now, which is the organization we both work for. And he has been doing this for his entire adult life. And that is why he is such a great policy wonk. Right?
I probably shouldn't be a policy wonk, but I guess through assimilation after 15 years working in the Medicare for All movement, I've become pseudo wonkish. So
yeah, it's an occupational hazard. It's
right. Yeah.
You come by it honestly. All right. So So 2 questions. I noticed we had 2 questions that are also kind of related to each other. Moving on from those were great questions about kind of, our current Medicare system, single payer systems in other countries, folks' fears about switching to a publicly administered healthcare system. But we have these 2 about incremental reforms before we get to Medicare for All. And do they help or hurt? So Gillian, do you want to hook us up with that first question? I do. I do. So this question is from Mary in Pennsylvania, who is a very good friend of mine and Ben's, and we love her. And she is actually one of the best human beings on earth. So I just want to throw that out there. And Mary had this excellent question. Do you think the Affordable Health Care Act helped or hurt the fight for healthcare for all? This is particularly relevant because Mary and Ben and I all met during the Affordable Health Care
I
Act.
remember that. Yes.
So it was worth it just to bring us all together.
Yeah.
Was it?
I think my answer to this very good question, did it help or hurt, would be both. I think when you look at it's funny because the Affordable Care Act was based on the Massachusetts health reform, which I, at the time before that, I was at the Massachusetts Medicare for All group. So we got kind of a preview of it.
Romney Care, right?
Romney Care, yes, as it came later to be known. So I don't know what you think about this, Gillian, but the political model of the Affordable Care Act was exactly the wrong political model, and I think was a bit of a setback. It was like, let's agree to spend more to cover more people, but not challenge the healthcare industry in any way. We're just gonna, keep the system the same, keep the healthcare system the same, and we're going to tell all these hospitals, insurance companies, physicians, hey, look, we're just going to dump more money into the system to cover more people. So it'll be a good thing. People have better access to care, and you don't need to worry about anything because there's going to be more money flowing into this healthcare industry, and it's going to line your pockets. So that was the coalition, right? It was kind of like the healthcare industry had a seat at the table to make sure they didn't lose any money, lose profits. I'm simplifying a little bit here, but and then
that's the basic story.
Yeah, and then patient advocate groups were like, all right, we can expand access for at least some people can get better access to care. So it was, I think it was positive in that it created higher expectations for like reaching universal health care, and it created this belief that we were kind of moving in that direction. And I think the Medicare for All movement has really exploded actually since the Affordable Care Act. So it has put some wind behind the sails of real Medicare for All. But that model where it's like we let the healthcare industry sit at the table and dictate what we can and can't do, we will never have an unbroken system with that model. So it can't be replicated for all the health reform we do from now on. But
yeah, I think there's like I don't know. I think there's something to be said. One metric, right, would be, would we still be sitting here talking about Medicare for All if the ACA had failed, right?
Right. And definitely not you. Yeah.
That's
right.
To me.
Well, didn't you kind of joined the movement around the Affordable Care Act, right?
I did.
Yeah.
I did. But what was really sexy to me was this Medicare for All thing y'all were talking about. Yeah. But yeah, no, right? Like, I mean, I just remember the 90s and, I was a kid then, obviously, but I do remember like hearing on TV about how they were going to fix healthcare. And then when it failed, there's like a good 10, 20 years before people were willing to take up the question again. And I think that was like a danger. And also I do think that it sort of brought healthcare into the discourse in a way that it hadn't been for like probably 20 years. Like you wouldn't have like the stuff that Bernie said, was saying about Medicare for All would not have been nearly as resonant, I think, if that whole huge politicized fight with the Tea Party didn't happen. I think that helped to radicalize some people.
Yeah, I think it kind of created a generation of healthcare activists who later were like, well, this is not enough. And I mean, it has been a pretty unpopular law if you look across the country.
Yeah.
And I don't think the lack of popularity is like right wing, this is evil Obamacare. I think it's that this is, totally inadequate for, that my healthcare crisis has continued. I mean, I think the Affordable Care Act, just when you look at who it helped and who it didn't help, it was, it about cut in half the number of uninsured people. So that was really important. And for that group of people, probably life-saving. But when you look at everyone else, the 90% of the the population, well, it varies from state to state, but the people who have some form of health insurance still have a healthcare crisis, can't afford the health care they have. We have rising deductibles, rising copays, limited networks. Our coverage gets worse and worse every year. So that crisis has kind of been totally unaddressed by the Affordable Care Act. It gets worse every year. It arguably was made worse by the Affordable Care Act, I think. A lot of this stuff, the limited networks, the high deductible plans, really exploded immediately after the Affordable Care Act was passed. So, mixed bag. And I think some people have been like, all right, we tried that, but we can't do that again, obviously.
I would be interested in thinking about it generationally as well. I feel like there's some study to be done there about the young people who got to stay on their parents' insurance.
Right.
Yeah. It's funny because the Obamacare passed in 2011 or whatever. And by 2016, a lot of those people had phased off their parents' health care, right? Sometimes when you give people a decent experience and then it gets taken away from them.
Right. Yeah.
Radicalizing.
Yeah. No, that's a great point. Yeah.
All right. Cool. So in addition to these kinds of questions, oh, wait, hold on. I forgot about Heather in Massachusetts. How could I forget about Heather? Heather had an organizing question.
Oh, I forgot about Heather in Massachusetts. That was thanks for picking up my slack here. Sorry, Heather. I know Heather.
Well, so Heather has this question, Ben. Here's an organizing question. How do we keep the momentum going for Medicare for All when we keep having to direct our attention and energy to an ongoing series of tangential attacks? So DCEs, ACO REACH. This attack on traditional Medicare was an existential threat to Medicare, and the Medicare for All movement did right by focusing on it, focusing its resources and power on this issue. But these kind of drip assaults keep pulling us from the primary organizing we need to do to move Medicare for All forward. Of course, all these attacks are related, but how do we keep our eye on the Medicare for All ball while having to deflect and regroup after every individual attack?
Gillian, I can't tell you how much I love questions that start with "here's an organizing question." And since I was supposed to read that one out loud and you saved my ass and stepped in and asked it, I feel like you should still be able to answer this one first.
I do. I also do like when a question starts with "here's an organizing question," because Heather has already understood the assignment, which is
right.
But yeah, this really does tie into to Mary's question about the Affordable Care Act, right? It's like we always have to balance in our work the fact that we are fighting for something that is going to be very difficult to achieve and is revolutionary, really, when it comes to the way that the American government and American society is set up, right? So we always have to have our eye on that. We always have to be working towards that. But at the same time, we always have to be balancing the fact that people are hurting now. Right. So I think, things like preserving Medicare, we need to do that, not just for the future, but also for the people who are, dealing with Medicare now. Right. I don't want my, elder relatives to be put on DCEs or Medicare Advantage. Right. And so fighting back against those things is really critical in terms of, kind of mitigating some of the immediate harm, right, that's being done by our healthcare system. But at the same time, we have to do that in a way that pushes us forward and pushes us toward Medicare for All. I think that's really the challenge.
Yeah. And if I could reassure Heather a little bit, I mean, again, this is my 15-year perspective on the Medicare for All movement. The moments when we really make surges forward in advancing the Medicare for All movement, where it's like we're really gaining traction, we're starting to get, grow the movement, get more activists involved, when we're starting to get wins in Congress or in state legislatures, it's usually when healthcare is somehow, one reason or another, put on the top of the agenda, either by us or by the other side, right? But either way, that is, I've had a lot of years organizing in this movement where healthcare isn't even on the agenda anywhere. It's not, there's no healthcare legislation being taken up by Congress. It's maybe, seventh or eighth down on the list of big topic areas, same thing with the state legislative attempts to get Medicare for All. And it is really hard to get folks mobilized, involved, excited. when there's just nothing, healthcare isn't in the news. It's not being talked about by legislators at all. And the best example I could give you, Heather, of this is when Republicans took the presidency, the House, and the Senate, and their number one topic was to repeal the Affordable Care Act. I mean, that was exactly one of these attacks that you're talking about on our healthcare, where we have to be in defensive mode, and we hate being in defensive mode. We want to be in offense. But that was probably the biggest leap in the Medicare for All movement in all the years I've been involved, where we saw a massive upsurge of support for Medicare for All around the country as people came out to town halls trying to oppose the repealing of Affordable Care Act. I was a little worried everyone would come out and be like, hey, we just want to keep the shitty healthcare we have now. But they actually didn't do that. They came out and said, we have to keep this at a minimum, but really we need a universal system. People who are totally unaffiliated with the Medicare for All movement were coming out and talking about Medicare for All. And this is where we like doubled the number of co-sponsors we had in the House almost overnight. So even when it's not great, when we're under attack, having healthcare on the agenda, I think it actually is an important mobilizing moment for the Medicare for All movement. And you can't just pretend like nothing is happening. Like, oh, we're going to, stick our head in the sand and pretend like the existing system is not under attack. You have to address it while you're building for Medicare for All. And I think doing both those things at the same time actually does work. And those are the moments when we tend to grow the most. So
that's so hopeful, Ben.
I'm so hopeful.
You are real
Sometimes
optimistic, high energy. This is a great day for Ben.
It depends on which day you catch me, but this particular moment.
it's because we're answering questions about organizing, which is the part of this.
Oh God, gets me so worked up.
I know.
Right? More organizing questions. If anyone on social media wants to ask us organizing questions, please just throw it in there.
Yeah, absolutely. Well, we do have this other question though on intersectional movement organizing, which. Okay. If there's one thing I love more than organizing, it's intersectional.
That sounded exciting from you. You were excited?
Yeah. All right. Yeah.
All right. So this question was from Kevin in Ohio. Kevin asked, what opportunities do you see to organize across constituencies in the fight for Medicare for All? I feel like coordination with the debt collective around medical debt could be fruitful, as well as organizing with the employees of insurance companies and other medical offices. Has any of this been pursued before? What seems most promising to you?
I think that, so I did a lot of work on bank campaigns with a bunch of international unions. Right. And one of the things they taught me was their organizing model, the pulpo being Spanish for octopus, right? And their organizing model was basically, it's very similar to any kind of corporate campaign that folks have worked on, but still the pulpo. So basically the idea is that if you try to catch an octopus by one leg, the octopus will actually drop off that leg and just swim right away, right? So if you want to catch an octopus, you got to rope it by all of its legs at once and then bash it over the head with a hammer. So
this poor octopus, can't we let it go?
I don't know. The octopus is in the story. So the point here being is that what these workers were doing, shout out to Committee for Better Banks, what these workers were doing is they were organizing at the regulatory level. They were making sure that Congress had their eye on the banks. They were organizing at the consumer level, telling consumers to speak up about what was happening at the banks. And they were organizing the workers of the banks, which is how this very long story becomes relevant to Kevin's question. And that ended up putting a lot of pressure on them. And if you want to see more about this, you can check out Dirty Money on Netflix, the Wells Fargo episode. But this was a very effective strategy, organizing all these different aspects, including the workers. And so I think it's a really good challenge for the labor movement to think about, organizing workers who are working in the terrible healthcare industry.
Yeah, and just the basic question Kevin raised, which is, which constituencies should we be organizing for Medicare for All, is a really great one and actually very hard to answer.
Yeah.
It's difficult because healthcare literally affects everyone. And unless you're a healthcare corporation, you're being negatively affected by the healthcare system, right? It's, and obviously not everyone is affected equally. But I mean, this is one of the reasons organizing around healthcare and Medicare for all is such a great bridging issue across constituencies. But I think the answer to the question is that our constituency, the groups that we want to bring to the table, are the folks who are affected most by the healthcare system, or most worst affected. Is that a good, properly framed sentence?
No, but we all get what you mean.
The people who are shit on the most by the healthcare system, I think, was what I was getting at.
Yeah.
Right. Those are the constituencies. So that means, and I think when Kevin's talking about the debt collective, he's talking about folks who organizing the folks who actually are dealing with medical debt is definitely a constituency most impacted by the healthcare system. And I would add in there, patients who have had denials, anyone who's been screwed over by the healthcare system, and then just the communities that we know are disproportionately impacted by the healthcare system. Communities of color are disproportionately impacted, Latinx communities, and
rural communities
disproportionately impacted. We had Suzanne Gordon on to talk about veterans disproportionately impacted by healthcare, those who can't access, especially the VA system, they have disproportionate health needs. And people with disabilities, people with chronic health issues, older people tend to have greater health needs and lower income. So again, it's still a huge group of constituencies, and it's difficult if you're an organization or a small group to be like, well, who do we reach out to first when it's such an overwhelming list? But I think it's important to do that exercise and to think about who has to be with us at the end if we're going to be winning this, and to make sure we're not leaving out groups from the movement and the movement decision-making process. So,
Ben, that was quite profound. Who needs to be with us at the end? Yes, great question. Who doesn't need to be with us at the end? Only the cool people.
Yeah. So, Gillian, what do you think about? We're 42 minutes in now. We've got through our big questions, but we do have some, we have some interesting extra questions. Some haters weighed in.
These are things that people want to know, and I am going to launch right into our next question.
Great.
This is an unattributed question. I plan on going to the Healthcare Now conference in April. Oh, wow, me too. All right, is anyone going to be there who is organizing the March for Medicare for All, M4A, in July?
All right, good question. Again, we try not to dodge these questions. I'm really glad you're coming to the Healthcare Now conference, and I know a lot of the folks who are involved with the March for Medicare for All are also going to be at the conference. It's an organization that generally has a strategic approach to Medicare for All that is completely different from ours at Healthcare Now. If you're interested exactly why we don't believe in this just throwing people into public marches as a strategy for winning Medicare for All, and we believe more in building power in local communities and moving legislators, then we did a whole podcast on this called "Do Marches and Rallies Work?" And it's a complicated question, but we do have I'd say we have a very different orientation towards winning Medicare for All than the March for Medicare for All. So that's not going to be the approach that's kind of the dominant approach at our conference. But
do you remember, Ben, one of the first times that we hung out, it was you, me, and Barney Frank. And we went to his office and we were talking about healthcare stuff, and everybody remembers Barney Frank, right? I hope, right? But we went to his office, and some of the folks who we were with were like, yeah, we're planning a big march on Washington. And do you remember what he said?
Oh, vividly. I talk about it all the time.
Me too. Yeah. He said, if you go out and march in Washington, the only thing you're going to be putting pressure on is the grass underneath your feet.
Exactly. Yeah.
Which was both a dickheaded comment and also just food for thought, right?
Yeah, it really summed up Barney Frank and a reality about marches in Washington, D.C., which they generally have very little impact on the decision makers who we need to win Medicare for All. Sometimes big marches, mass marches can have a movement building effect, but they can also do the exact opposite. They can diminish the actual local organizing that's happening in the movement.
And we love direct action. We should say that, right?
Exactly.
So the issue isn't just the march. It's how does the march become a tool in an overall strategy that actually, pulls people into the movement and doesn't give them that feeling like, oh, I went out and marched, I'm done now.
Right. Exactly. Yeah.
Yeah.
So anyway, but this is one of the many ongoing conversations in our movement. I love these things because as movements grow, you just have more and more people coming at how to win this thing from different angles. And we already had, some of the core groups who we work with all the time have different orientations than we do to how we win this. But it's kind of the beautiful messiness of a growing large social movement. So I appreciate your following the podcast, emailing us with questions. Love it. And we'd be happy to talk more off the podcast if you want to as well. So,
Awesome.
All right. Last question. This, I think, falls under the hater category, Jillian. I'm going to read the whole thing from Thomas Cox in Florida. And you get to answer this question, Jillian. So, yes. So, Thomas writes, why, after many efforts on my part, is healthcare now still ignoring the elephant in the room? Common healthcare financing mechanisms embedded in Medicare/Medicaid and private health insurance transfer insurance risk to healthcare providers, making those healthcare providers de facto health insurers and claims agents for their patients. As small and efficient health insurers, they have no alternative to reducing the quantity and quality of care they plan to provide to avoid losses and insolvency. I have offered my book, Standard Errors, Our Failing Healthcare Finance System and How to Fix Them, for free repeatedly, in which I describe exactly how this all happens. And yet you waste your time and effort distracting people from the root causes of the disaster unfolding in our country's healthcare system, wasting my time, sending me emails that further convince me that you are wasting people's time and are part of the problem, not the solution. Jillian, how do you respond to this, wasting people's time?
Go fuck yourself. I don't know. Is that appropriate? Is that inappropriate? So it's like, I just hate this kind of argument. Like, I hate this kind of argument. It hurts my brain. I don't like it. I mean, I think, it comes back to what actually changes people's minds, what persuades people to get involved, what gets people activated. And let me tell you, a discussion about capitation is absolutely not going to get people excited. We want to be talking about decapitating. Some of the executives that were just kidding. NSA, we're fine. So yeah, I mean, this kind of like wonky argument is like, that's kind of a waste of my time, I think.
Yeah, I mean, I can't understand this level of like visceral hatred for us, that we are focused on organizing work around Medicare for all, and that we are not focused on the precise exact policy argument that Thomas thinks we should be taking. As organizers, there's a lot of actual research and evidence, if you want to take a policy approach to organizing and winning a social movement, that focusing on, really high detailed policy arguments is not why people care about fixing healthcare, and it's not how you win healthcare. I mean, think back to the civil rights movement, or women's suffrage, or equal marriage movements that have had, significant success, even if not total success. And if you think back on your vivid impressions from those movements, were any of them like policy or legal arguments? No, it was people who had their lives ruined by inequities in our legal system and our social system, our economic system, making profoundly moving moral calls to action to change an unjust system that's really hurting people. So that's what we do. And excuse us if we're not making, the exact right policy arguments about, yeah.
I guess I think there are some people in the world who believe that being right is enough. And this is one of the great messages of my life, which is, being right is never enough, actually. And if you think about it, like, I think a lot of people, the way a lot of people conceptualize things like the civil rights movement is, all right, Martin Luther King, he said this thing, and he said it just the right way. And that's why everyone got excited or whatever. No, Martin Luther King and Rosa Parks were sitting there for months before the Montgomery boycott, sitting in the Highlander Center, learning how to organize in Newmarket, Tennessee, by the way, shout about Highlander. But they were sitting there learning how to organize and building up their skills and learning how to build relationships, right? These kind of things, you can't just come up with a great idea. A great idea doesn't mobilize people. Organizing mobilizes people.
Amen, sister. This is actually, going back to the very first question, this is why it is so wonderful working with Gillian Mason at Healthcare Now and on the podcast. I love that closing comment. But it's also good that we're right all the time. It helps to be right in addition to organizing for power. So I just wanted to close by thanking our podcast team so much. Our podcast manager is Angelique Davis. We gave our researchers the week off to take your questions, but Jerry Katz wrote up our show notes and Christian Brandt was our audio editor. So thank you so much. And we'll be back to an actual topic in a couple of weeks from now. Bye, y'all.
Stay